Hello, everybody. This is a debate. It's kind of hard to do a debate on this. I think I use all the stents, all three stents, pretty routinely in my practice, and I think that they're amazingly good. And compared to the first generation of DES, they've really made a great advance, and I'll prove that to you here. These are my financial interests. I am globally conflicted. I like that word. I'll use that word as well. Dr. Hermiller. The Resolute Integrity Stent, you saw these kinds of slides before. The drug is an Olamus drug, so it's similar in its mechanism of action. The delivery system is a bit different. It is very deliverable. It does have some different properties with respect to the access to side branches, but there may be some anatomic situations where you might want one over the other, but this is an extremely deliverable stent. The big change on this stent compared to the Endeavor stent is the drug release kinetics, which now are released over closer to 6 months as opposed to a couple of weeks, which was the Endeavor. And this provided a much enhanced efficacy. So I'm going to focus on just one or two quick slides, quick trials. I think this is a really cool trial, the Resolute All-Comers trial. And what I like about this, for those of us who take care of a lot of patients in the cath lab, this is a very relevant trial because it's an all-comer trial, and it's not a highly selected group of patients. I think one of the problems I have with this kind of debate is that I kind of think any one of us could take any side. You just have to pick the trials that favor your stent the most. I mean, you can always find some trials that do that. Be aware of that as when you look at this kind of data. The all-comers trial was pretty big. 2,000 patients, Zions V versus Resolute, and with 5-year outcomes, and it's randomized, so that's pretty good compared to the historical data kind of trial. And what you saw earlier were some historical data trials mixed in with randomized trials, so be aware of that. And so if you look at the inclusion criteria, there's just no limitation. Number of lesions, number of vessels, basically what you're treating every day. Lesion length, they had to get informed consent, that was about it. And then the exclusions are very minor things, people who are intolerant to dual antiplatelet therapy or having surgery within the next 6 months. So a very, very robust group of patients. And when you look at the baseline characteristics comparing these two stents, it's consistent with what we just said. The bifurcations in 15%, small vessels in 2/3, acute MIs are included, ACS patients, men and women, and ISR is even included here. And if you define complex patients as done in the very fine print here, which I actually can read now that I'm wearing glasses, it's about 2/3 of the patients were complex, and this just again illustrates the type of complexity that we deal with pretty much every day, then certainly that you're seeing at this conference here on a case-to-case basis from Dr. Sharma and his colleagues. So target lesion failure, which is an FDA kind of definition that I know is a little bit cold for us, leaves us a little bit cold because it's cardiac death or an MI due to the target lesion or TVR. It's a little easier for us to look at the endpoints individually. Cardiac death, this is at 5 years. So this is, first of all, these results are spot on compared to the Zion stent. It's just the same. And you could say, well, cardiac death, it's good to know this. In this day and age, patients you're treating, you got about 1% per year death rate. And target vessel MI about the same. TLR rates, these are pretty small, low TLR rates. It's not TVR, by the way. So TVR is going to be a little bit higher, target vessel. But the target lesion rates are under 10%, and that's pretty outstanding at 5 years. And I think that mimics our practices. We see restenosis for sure, but we don't see it like we used to see it. If you look at this target lesion failure and look for subgroups where one stent might have done better than the other, you can see if I want to be a zealot for zotorolamus for this Resolute, I can say, well, it seems to be better in ISR or STEMIs, but it's actually not. The p-values are not different, so it's pretty equivalent. Stent thrombosis, this slide was heralded by my competing speakers because it shows, by the way, a trend. This is why we have statistics. It's not statistically significant. The p-value is 0.22 of a higher thrombosis rate, and that was all due to the early thrombosis here, but it's not significant. And a very late thrombosis is the same. Then the point is made that the Resolute all-comers trial, if you want to blow it up really big so you can see the difference and don't include the error bars, this is how this is how the stent wars go. Which is, just be aware of this when your sales rep comes to show you these data, that this is kind of a selected data. So we make it look really big, this difference, and then we can go to another trial, which is same kind of trial, which showed just the opposite. So it really does not appear to be a quote signal of a thrombosis difference. If there was, I wouldn't use the Resolute stent. Another way to look at it is look at all the Xience V stents compared to the Resolute and all these different trials, and you can see it's all running about the same. These are different time frames, but the point is that the stent thrombosis rate, this actually is all under 12 months. 12 months, we're talking about 1.5% stent thrombosis. Again, mimicking our own experience. In fact, I wonder whether the thrombosis rates we see, and even some of the restenosis rates, couldn't be due to either the polymer and drug rubbing off the stent when we put it down complex lesions, maybe manufacturing issues. It can't be perfect, right? There's got to be a certain percentage of stents that struts that don't get the drug on them. I mean, none of these systems are perfect because these drugs work very, very well. And I also suspect that they're safer than bare metal stents. I would actually disagree with what was said earlier, that the bare metal is the historical gold standard for safety. I think that these new polymers seem to, if you look at some of the meta-analysis, some of the other meta-analysis, they seem to, if anything, improve stent safety, in my opinion. If you want some backup for this, this is the whole Resolute global clinical program. A lot of patients, trials are all different, but the point here is that if you look at target lesion revascularization, it's about the same as what I just showed you. So there's a lot of backup for these data showing low target lesion revascularizations, low stent thrombosis, around 1% at 5 years in a lot of data. The pooled dual antiplatelet therapy, you've already seen trials like this. So it was done with everolimus and it was done with zotorolimus. As here, 7,000 patients, and looking at stent thrombosis when DAP was interrupted. So here's your 7,000 patients down here. DAP interruption 13-15, and broke it down to if the interruption was within the first month or not. And this data, I think, is pretty compelling and has informed my practice. The patients with no interruption, 0.73% thrombosis rate. With interruption after 1 month, it was none, 0. Interruption earlier than 1 month, about 4%. So I am beginning to, I don't know, we can discuss this if there's a panel discussion. I'm beginning, if I have a patient who needs surgery, has cancer, I'm a little worried about him. If the lesion is a complex lesion, if it's a big, huge LAD, I'll put a bare metal stent in still. But if it's not an easy lesion, I'll go ahead and put a drug-eluting, a DES in. I actually usually use Resolute for those patients. And then if I have to stop Plavix, or the newer antiplatelet agents, as long as it's after a month, I feel more comfortable. Particularly, I kind of give it 3 months. But I think you can think about these stents in terms of using shorter antiplatelet therapy if needed. The data is not perfect, but I don't really get too concerned if it's 3 months or more. Finally, diabetics, say a word about that. Looking at several of the Resolute trials, and we have a total diabetic population from these trials of 1,500 patients, and then they did a matched cohort. This is a lot of statistical analysis, so I'm not as comfortable with this data. What they did was basically take out any of the complex patients and make it easy patients. And if you look at the sort of standard kind of type A lesions in diabetics and compare it to a performance goal, I really don't like these kinds of trials because it gets very shaky, I think, the data. But it did show improvement over the historical control. And the importance there is that the FDA has actually given this stent an indication for diabetics, which is something that the other stents that we're talking about do not have. So that's something to notice. In summary, latest generation stents, I think all of them provide impressive outcomes. The Resolute stent TLR rate under 10% at 5 years. Stent thrombosis rate about 2% or lower, probably lower at 5 years. Need for prolonged DAPT is less clear, and interrupting DAPT after 30 days is probably safe. And I want to close. I have 11 seconds. I want to go over 30 seconds. I'm collecting funny cath lab videos. So I'll show you 3, and you can help me. You can send me some. This is one of our cath labs. It's about 10 years old. We don't know why it does this, but it seems to, we call it cath lab on drugs. It just, all of a sudden, it decides to do this to us. This one is, where's the next slide? Okay, maybe click over there. And world's worst runoff. Bill Gray would like this. This is really worth watching. So he's stripped the intima of the entire. This was done at some other hospital, of course. And his first day of fellowship, he wants to make sure he's in the right place, and it's not bad, not bad. And I do have one more last slide. Those of you should all know about this. If you don't, I assume most people here are upset about the maintenance of certification requirements, and we're trying to change that. I think we're making some progress. As of this morning, we have 16,500 signatures. Go to this site, or Google MOC change, or recall MOC, or my name MOC, and you'll get the site. Just sign the petition, put your email in so we can contact you, and I think we're going to try to make some significant changes on the maintenance of certification. Thank you for your attention.